two major things: clean water, clean drinking water, and adequate food are responsible for about 70% of the life gain in terms of life expectancy from 100 years ago, when people were living 45 years or whatever. 70% of that is those two things: clean water and adequate good nutrition. About 20% come from the antibiotic revolution, and the remaining 10% was all the other drugs and surgery and procedures combined.
Yeah, but you didn't factor in all the people dying from medicine too. You got to subtract all.
Right. Well, I mean, that's the thing, is that medicine has co-opted the gains in human health that actually came from public health, and people don't realize that they were public health measures as opposed to medical measures. I mean, even, as controversial as a topic as it is, vaccines, that's public health. That's not medicine. Just because a doctor gives the injection, that's not something that you go to the doctor and the doctor says, oh, I think given your condition that you're 3 years old and you're about to go to school, you should receive this medication. No, those are public health mandates. And so the one thing that was left, that you left out, that figures in there somewhere, Jay, is public health regulations regarding housing and the number of people that could live in a single unit, and how many families can live in an apartment that has just one bathroom or whatever, all those sorts of things. That also stemmed a lot of communicable disease and other issues. One thing, if I can just throw it in there, is that I also think that medicine takes credit from public health, because it took me a long time to understand where that line really should be drawn. But I would say, I don't think I've read it anywhere, but I would say that clinical trials are public health. It doesn't become medicine until doctors start to employ, say, a new drug or a new protocol, until they start to implement that in the clinic and it becomes clinical practice. Then that is medicine. But the construct of requiring clinical trials or choosing to use clinical trials as a way of justifying making shifts in medical care, that's public health. And the very fact that you use statistical analysis on large populations, that's the antithesis of individual treatment. And so it's a funny thing, because I don't know if it's like the snake eating its tail or what metaphor, but individualized, personalized care in medicine. I have a graphic that I created because I'm a big proponent of using big data to focus on individual issues. And my magical, erudite phrase is e pluribus unum. And to take the insights gathered from huge pieces of data and from maybe even huge populations, and then seeing how can you apply that to an individual, but treating that individual as an individual and not as belonging to some particular part of the bell-shaped curve that we have no way of knowing whether they belong to, because, the clinical trial was run in Croatia and my patient is Haitian and living, in Iowa. And so it's like, does that study really apply to that person? So that transition from a public health insight of a clinical trial and to translate that into a clinical N of one decision, to me, that's something that's done rather imprecisely.
Yeah, that's that's the field of translational medicine or whatever.
Yeah.
And, I was just going to tell you, in my training in the medical geography, I studied, there's a book, Clinical Epidemiology by Noel Weiss, who was here, and my mentor, who was both a professor of public health and geography, Jonathan Mayer, he was like, he was very, like, the entire book was all like design of trials, like, because it's under clinical epidemiology is like both case control studies, retrospective, prospective, all like the randomized trials, controlled trials, all these various different types of trials and designs are coming from the field of epidemiology and public health to assess risk benefits, in certain whatever settings you have. So definitely public health is really important to medicine for the goals that we want, and they need to go hand in hand much better. And I've always wanted to think of myself as a public health doctor too, that, we're acting, as you say, from the many, which is like the data, the understanding of what's going on, and what the needs are from a public health standpoint, and understandings are, I guess, and then translating that into, well, how does that apply to my particular patient who has some of these features but not these other ones? So how do you kind of, that's the practice of medicine. That's
Right.
part of the art and science of it, is knowing how to make those movements on scale. So anyway,
Yeah,
I just want. Yeah.
I was just going to add one little addendum. I think if you look at the history of medical experimentation, like I was saying, that clinical trials are more of a public health vehicle, because if you look at what doctors typically, let's say in the early 1900s, did when they wanted to experiment with a new therapy, they would just try it out on some people. Immigrants, they would give
Prisoners.
syphilis to a bunch of guys. Yeah, but with no control group, no informed consent. I mean, any of those other things, all those other things that constitute clinical trials now are public health or ethics, medical ethics mandates. They didn't come from the doctors that were curious. It's like, yeah, I wonder whether or not, chamomile can help, babies stop crying at night. They would just give it to a bunch of moms and tell them, yeah, just give it to your kid, and then tell me how it went. That's not a clinical trial.
It's observational understanding. Sometimes you can do, if you do it in try to do something systematic about it. But I do think ketamine, which I use a lot in my practice, I recently prepared a talk and found the first trial that was done in humans with ketamine was done in prisoners, and by the company, by Park Davis. Edward Domino, I think, was the principal investigator. And I don't know what prisoners they used, and if they knew, hey, you're getting this new PCP alternative, like, are you cool with that? I mean, it might change your awareness of like why you're in prison, or you want you want more time in the gym. Well, maybe you should do this trial. Like there was probably all kinds of terrible and perverse
incentives.
Yeah. I mean, I would have done it too. But anyway, that's just an interesting aside in terms. The problems they point to are rising obesity, rising sense of depression and anxiety and addiction in the world. They talk about rising income inequality, haves and have-nots. They talk about the huge impacts of global climate change, global breakdown of all the environmental controls that we were talking about earlier. They talk about it's just you could think of like I would put into that list. And this was written well before coronavirus, rising pandemics. I would put into that rising violence, like levels of social unrest and violence and mass violence. These are like some of the more complex problems, and we could probably make a larger list. I've got a list someplace in here, but what they say is that these problems they say we now need to move into this new wave, which is centered on well-being and what it means to be human. Like it's like we gotta because they sort of say a lot of the central issues in here have very much to do with this sense of loss of meaning, loss of centralizing well-being in some way, people working in a system they're not happy with, and all these kind of things. And in palliative care, which is what I trained in, like we very much have always kind of looked at that meaning and purpose box as part of an assessment, because somebody's going to have a miserable and last few weeks of their life if they're dealing with a terminal illness, if we're not attending to all of these things all together, because those become serious situations where that box, if it was neglected, as those two boxes, will completely ruin that patient's quality of life, their symptom burden, their hospitalization, the family who lives on afterwards. So I'm just kind of bringing that into this, and they're saying let's apply this whole thing writ large. They give examples, and I feel like if we can get into that kind of mode where public health is a lot more engaged in some of these more complex interlinked problems, we're not just in these little silos I'm just going to vaccine our way out of this problem.
Sunil, that just, that whole fifth wave stuff was, I lit up. I was forming synapses because I was like, oh my goodness, and it makes so much sense. But risk factors, lifestyle, exercise, prevention, diet. It sounds like we need a complex and interactive physiologic system to help deal with all that. I wonder what that could be. Something that is involved and is involved in weight gain and obesity, depression, anxiety, the endocannabinoid system, of course.
Wouldn't it be nice if there happened to be a system?
Yeah, and then you even mentioned global climate change. There are papers, and I'm sure Dominic would be the first guy I would call, but with hemp, we could feed the entire planet theoretically, as well as many of our animals with hemp. And it's so good for regenerating soil. It's a carbon-based sink. So this whole idea of medicine being just the THC or the cannabinoids, it's not just that. It's the whole apparatus that is set up around it. And I know, admittedly, a lot of cannabis is grown indoors, so that eliminates the carbon sink feature.
It's only indoors because of the policies. Like, traditionally before 1980, I'd say 1970, like for like thousands of years until 1980, it was outdoors. And
right.
then,
and still, yeah.
What's that?
Oh, and still, the plant is just so insect hardy, and the taproot can go 3 to 4 feet deep, which can aerate. It goes and it finds its own water, and then it aerates the soil so that the next year the soil is better. Just
that's what I've heard. That's what I've heard. Agriculturally, there's absolutely lots of good reasons to use cannabis, and I even had a friend, Paul Hartman, who's a brilliant guy, who was also Humboldt and marine biologist, and he was for years, like 20 years ago, was writing to UN, like on these listservs, UN Food Agricultural Organization, like staple for famines, like you need to get hemp seeds in there. You need to have hemp because that's really going to help with these, like whatever other cassava or other like staples you're using in these famine situations for food relief. That this has this all essential amino acids, complete protein content, and all that stuff.
Wonderful lipid profile. It's got, I believe it is a 4-to-1 or a 3-to-1 omega-3 to omega-6 ratio, which is what an ideal diet consists of. You look at chia or flax or others that have good omega-3s in them. They don't come in that ratio. It really is just a wonderful food. I had toyed for a while with, it's kind of not as cutting edge anymore with Elon Musk and everything, but writing about cannabis in space and the benefits of cannabis in space. It's a perfect food. It's a medicine that can be used
for space food.
But really what that is it's a rhetorical trick, because all of those things work right here on planet Earth. It's not
like Jake was saying, like we really gotta, this cannabis and the endocannabinoid system is all really, I think, is part of this larger wave of public health, because it forces, it's a new understanding that connects a lot of these disparate things in the human physiology, and I think mind, body, spirit, and also maybe even at the social level. There's a lot of interesting work on social exclusion and the impacts that has on the cannabinoid tone, and if you actually take cannabinoid booster like Tylenol before you play a psychology game where you get excluded, like there's some studies where they've done this to poor volunteers, like you're playing at something and they're like, oh yeah, you can't be on the team anymore. They just randomly kick people off. But if
they lose their empathy.
Right. But yeah, well, if you take, first of all, when you get kicked off, like apparently if you take Tylenol beforehand, you don't feel as bad. And I don't know if that
that's the empathy part. The empathy part, yeah.
I don't. You just don't care. You're not as empathetic with your. Like if you are more empathetic, you might still feel better or worse. I don't really know. I'm kind of confused as to, because I've also read that Tylenol can blunt empathetic responses.
Right.
But it also
so it blunts empathy. It also blunts performance, anxiety, and assessment of quality of personal performance, kind of similar to alcohol, where people think that they're driving better than they actually are. So
or singing better.
It's actually a pretty powerful psychoactive drug.
Yeah.
Well, yeah, and the whole I mean, personally, I will take buffered aspirin before I do a big travel, not for the anti-inflammatory aspect, but because I've just found that it really helps my stress as I'm going. You know, the TSA line that stresses me out. You know, I'm like, are they going to get me? No, I mean, I'm just kidding with that. But I found, I mean, that's just a personal observation, and I just realized that over a number of times where, oh, I might have had a sore back or a sore neck and I was traveling, so I would preload with I usually prefer aspirin if I'm going to do an anti for personal reasons, but I found it very good for stress relief, and so
that's interesting. I mean,
I'm
people
gonna
don't talk
replicate
about that aspect of aspirin much at all, and you know, it could be this the sort of the new old understanding of inflammation is really not just you know, Greg Gerdeman was recently interviewed. He's back in Tennessee. You know, I don't know if you guys know Greg. He's a brilliant Ph.D. You guys know Greg Gerdeman? Have you come across him before? Oh, he's like one of the most brilliant cannabinoid scientists that I've had a chance to meet over the years. I've been Gregory, last name is Gerdeman, Gerdeman, maybe two N's in his last name. He was one of the first people that discovered retrograde signaling in endocannabinoid synapses under NIDA when he was doing his PhD or postdoc.
Oh, wow.
You know, NIH, NIDA grants, so he was really on the cutting edge of cannabinoid physiology understanding in the 90s. And I met him at an ICRS meeting in 2005, and you know, we've been friends ever since. And he kind of then became a professor in Florida, and now he's pivoted into kind of cannabis science officer for companies and things like that. But he's an excellent communicator and educator. He was the go-to guy for explaining at the American Chemical Society special section on cannabinoids what's going on with delta 8 THC and like the whole like what's that all about, and you know, like what do we know and don't know. Anyway, so he had recently did an interview. He's back in Tennessee where he grew up. He's kind of moved there, and you know, the local paper, because there's no law for cannabis in Tennessee, or there's nothing really like legitimate, so people are still trying to prevent themselves from going to jail for talking about and using what we're talking about here. I think it's still kind of in that world. I don't know. Anyway, but he was saying the big three for cannabis, that delta 8 can potentially work for that. He was like talking about pain, anxiety, and then sleep. But then with the anxiety, he says anxiety / inflammation. So like he kind of puts anxiety and inflammation on the same part of the stool, which was it was nice to sort of see that kind of aha that he was.
I like that.
He's saying.
And to tie in with kind of what Karyemaitre was talking about in terms of, do we talk about cannabis in terms of a health model or a pathology disease state model? A lot of the times, what I've been talking about lately is I use those big three, but I'm going to start adding the inflammation, pain, anxiety, and sleep. So many patients with other conditions you have a diabetic patient with osteoarthritis and knee pain that's preventing them from sleeping. Cannabis stands a good chance of helping them sleep, but it might also help with the knee pain and the osteoarthritis. And you know, if there's THCV, it might actually also impact the blood sugar.
Diabetes, yeah.
So many patients have one of those big three. So to utilize cannabis or in conjunction, you know, with Crohn's, a Crohn's disease patient just had a hip replacement, 3-4 weeks ago. And is just wanting something a little bit to take fewer NSAIDs. You might be treating a specific problem, but it has global impact. Kind of like what you were talking about with the fifth wave, all of these things we see interconnecting. And now finally we have a system that we see is essential for the proper working of all the other physiologic systems.
I forgot to mention, so you've kind of brought cannabis back into that larger public health discussion. You know, there's an amazing researcher at University of Indiana, and I'm blanking on his name. He was the one that first published some of those studies on the link between cannabis use like 3 times a week. And, you know, Ethan was mentioning it in his talk about, you know, the population studies that were showing cannabis reducing BMIs, you know, like obesity. Like I think Ethan said 3, like on average, if people had used some form of cannabis, and I think it's THC containing cannabis 3 times a week, or have some frequency like that, then that in general their metabolic function was improved. And so the guy that published that, and I'm blanking on his name right now, sorry, I can pull it up, but he's pretty brilliant public health professor there at Indiana, and he actually has done a much larger analysis of what kinds of public health benefits there would be based on all the studies he collected, you know, epidemiologically, cancers and heart disease and neurological conditions. And he was able to like kind of extrapolate from that based on like what we know. And, you know, again, there's always like a little bit of fuzziness when you extrapolate from 6 data sets to a larger population. But, you know, that's part of the whole field of public health, is how to actually make those in a way that's reasonable, controlled, and, you know, within whatever limits. But see, he did that. You can like find his entire analysis, and he showed how many less deaths there would be if the population, if this was available, the population level, and he put in a bunch of data pieces. Like it's like a big data analysis, like even those Medicare data and everything. How many thousands of less people would die from cancers, heart disease, a few things. And it was really it's a brilliant data set. And he sent this off to a journal to, you know, and it was accepted. You know, they were going through the process. Okay, accepted with revisions is what they said. And so then he was making the revisions, and then some other like editor came on, and they reversed their decision and completely rejected. Like, and so it was so controversial, even though like if you look at it, like the data analysis is very sound. I think it was like, I forgot which journal, like the BMJ or some mainstream public health journal. And so then University of Indiana has like the library has something called ScholarWorks, where, you know, it's kind of preprints, or like any research you're working on, you can just publish it like through the library. And so all of that is available and he has all the correspondence with the peer reviewers. So you can see like the total bullshit that they did. I couldn't believe it. Yeah, so I cite that guy and those findings in that chapter because I think that he was onto something so big. You know, that's just one botanical medicine, you know. And of course, it has to be available, accessible, clean, the right types, so many different things involved. But really, like, that's what the scientific analysis can show you. And we actually hear the numbers. So that's the kind of thing that I think public health can bring to the public debate.